Hey everyone, welcome to my channel. This is my first video, and on this channel I'll be focusing on dental content, specifically for board exams like the INBDE, but I may also delve into other things in the future. We'll see. Anyways, in this first video I'll talk a bit about endodontic diagnoses, talking about some of the tests we can do, and focusing mostly on the diagnoses that were published in 2017 by the American Association of Endodontists, which is what they will ask about on most exams. And I just want to say that I won't be going into detail about every single thing, I'll just be focusing on the more important stuff. So let's get started. Typically, root canal treatment, and I'm of course referring to non-surgical root canal treatment here, is considered a safe procedure for everyone, with a few exceptions. Specifically, a myocardial infarction within the past 6 months, uncontrolled diabetes, and uncontrolled hypertension are the only contraindications. In general, you should always take a comprehensive medical history, as certain conditions may require modifications to the treatment plan, while others may necessitate prophylactic antibiotics to be given. How well a patient can point to the location of pain depends on whether the inflammation is still confined to the pulp tissue. If the inflammation hasn't reached the periodontal ligament, the patient may find it hard to pinpoint the exact location of the pain. This is because the nerves in the pulp only transmit pain signals and not information about location, whereas the periodontal ligament has nerves that sense the tooth's position. So if the inflammation spreads beyond the tooth's apex, it becomes easier for the patient to identify where the pain is coming from. Before talking about the diagnoses, let's briefly go over some of the diagnostic tests that can be performed. It's important to perform the test on multiple teeth, including adjacent teeth, opposing teeth, and contralateral teeth. This is because people have varying pain thresholds, so testing several teeth can help determine whether a specific tooth is actually responding differently or if that's just the patient's normal response. The Cole test is the most commonly used and is usually done using a refrigerant spray which is composed of a chemical called tetrafluoroethane with the brand name Endo-Ice. A cotton pellet is sprayed with the chemical and applied to the tooth surface at a temperature of about -26 degrees Celsius or -15 degrees Fahrenheit. The chilled pellet is applied to the middle third of the facial surface of the crown of the tooth. The patient's reaction to the stimulus, including intensity of discomfort or pain, as well as whether the pain disappears when the stimulus is removed, are all things that are considered to help make a diagnosis. Anyways, in general, you want to make sure that the tooth being tested is completely dry and that the tooth is isolated so that the cold doesn't come into contact with adjacent teeth or the gingiva, which would give you a false positive. The heat test is not very common, but it can be performed when the patient comes in complaining of pain when eating or drinking something hot. And there's a few different methods to perform this. Rotating a rubber prophy cup on the tooth to create friction, heating a gutta percha cone and placing it on the tooth surface, or isolating the tooth completely and basically bathing it in hot water. The electrical pulp test is a method to determine if there are any functional sensory nerves still present in the pulp. However, the presence of nerves isn't what determines whether the pulp is still vital or not. That's determined by whether there's still blood flow to the pulp. So the electrical pulp test isn't super reliable in this regard. And in general, the electric pulp test is considered to be less reliable than the thermal test, as it can give misleading results, both false positives and false negatives. Some examples of false positives would be a very anxious patient, or the tooth not being isolated properly, so the gingiva is touched by mistake. And some examples of false negatives would be a tooth that has recently been through trauma, or a tooth with calcified canals, or for example, if the patient is taking painkillers, which would increase their threshold for pain. During the examination, it's also important to assess both the hard and soft tissues by palpating. The palpation test involves pressing firmly on the mucous membrane that covers the roots and apices of the teeth with your fingers. You should look for any signs of swelling and compare the tissue around each tooth. You should also pay attention to any areas that cause pain when touched. If there's pain in the periapical area when palpated, it could mean there's inflammation, but it's not possible to determine solely from this test if the inflammation came from the pulp or if it's a periodontal issue. The percussion test is helpful when a patient complains of sensitivity or pain while chewing. The test is performed by tapping on the incisal or occlusal surfaces of the teeth using either your finger or a blunt object like the back of a mirror handle. If there's pain on percussion, it could indicate inflammation in the periodontal ligament. However, it's important to keep in mind that this test alone can't determine whether the pulp is vital or not. While it's true that infection could have spread through the pulp tissues and made its way to the periodontal ligament space, inflammation in the area could have also been caused by trauma, high fillings causing premature contacts, or periodontal disease. Okay, now that we've gone over some of the tests, let's now move on to the different diagnoses, starting with the pulpal ones. A normal pulp is asymptomatic and responds to pulp testing normally, meaning if we tested it with thermal or electric testing, we would see a mild or moderate response that would disappear when the stimulus is removed. Reversible pulpitis is inflammation of the pulp, which can return to its normal state upon removal of the causative irritant. However, if the irritant isn't removed, the condition may progress to irreversible pulpitis or pulp necrosis. In cases of reversible pulpitis, the patient may experience sharp pain to thermal stimuli, most likely when they eat or drink something cold. However, the pain will go away soon after the stimulus is removed. It's important to note that unlike irreversible pulpitis, which we'll discuss in just a bit, reversible pulpitis does not cause spontaneous pain. Clinically, the presence of cavities or dental restorations may be seen, and the radiographs would show a normal appearance of the periodontal ligament and lamina dura. Tests such as cold test would reveal sharp pain that doesn't linger, and there would be a normal response to percussion or palpation. If ignored, however, reversible pulpitis can eventually progress to an irreversible state. Symptomatic irreversible pulpitis means the pulp has reached a state where it's permanently damaged and isn't capable of fully returning to normal, even if the causative irritant is removed. So simply removing the source of the inflammation is not enough, and a root canal procedure is indicated. Distinguishing between irreversible pulpitis and reversible pulpitis can be done by looking at two key things. Firstly, in the case of irreversible pulpitis, pain may linger for 10 to 20 seconds or even longer after the stimulus has been removed. Secondly is the presence of spontaneous pain, which is not seen in cases of reversible pulpitis. And according to studies, changes in posture can affect the flow of blood to the pulp, so some patients may experience pain during the night that interferes with their sleep. Radiographs are useful in cases of irreversible pulpitis, however, they shouldn't be used alone to make the diagnosis. Some of the radiographic findings that could be seen are radiolucency extending to the pulpal space, widening of the periodontal ligament space, and a periapical radiolucency in advanced stages. Next, we have asymptomatic irreversible pulpitis, which is kind of a weird one. It's similar to symptomatic irreversible pulpitis in that the pulp is unable to return to its normal state, yet the patient may not experience any symptoms. But despite the lack of symptoms, inflammation of the pulp is evident, either due to caries that have reached the pulp or due to trauma, and if left untreated, it may progress to the point where symptoms develop or may lead straight to pulp necrosis. The stage following irreversible pulpitis is pulp necrosis, which is the death of the pulp tissue. Pulp necrosis may result from untreated chronic pulpitis or a traumatic injury that cuts off blood supply to the pulp. A tooth can undergo either partial or complete necrosis. With partially necrotic teeth, some symptoms associated with irreversible pulpitis may still be present. Completely necrotic teeth are asymptomatic and do not respond to thermal or electrical pulp tests. However, long-term necrosis may cause infection to spread beyond the apical foramen, leading to periodontal ligament thickening and radiolucencies visible in radiographs, and tenderness on pain while chewing or during percussion of the tooth. Now we have previously treated, which by its name means that the tooth has undergone endodontic treatment in the past and the canals have been obturated. On the other hand, previously initiated therapy means that some form of pulp therapy, such as a pulpotomy or pulpectomy, have been performed on the tooth, but the canals are not completely filled with an obturation-filling material. Now that we've covered the different diagnoses related to the pulp, let's shift our focus to apical diseases. Specifically, apical diseases that are of pulpal origin, meaning they occur when the inflammation spreads to the apical tissues through the apical foramen. Of course, you should know there's also apical diseases that are not of pulpal origin, but we won't be discussing those in this video. Firstly, of course, we have normal apical tissues which are asymptomatic and there's no pain or discomfort on percussion or palpation, which are two of the tests we discussed earlier. Symptomatic apical periodontitis refers to inflammation in the tissues surrounding the tooth's apex. The primary cause of this is inflammation in the pulp that extends to the apical region. However, performing pulp tests to confirm the diagnosis before starting any endodontic treatment is crucial, since it may not always be the case. Because in addition, apical periodontitis may occur due to over-instrumentation of the canal or obturating beyond the apical foramen during root canal therapy, as well as occlusal trauma like bruxism or high filling. When symptomatic apical periodontitis is present, patients will typically experience pain on chewing or percussion of the tooth in the clinic. Asymptomatic apical periodontitis is inflammation of the tissues surrounding the apex of a tooth with no other symptoms apart from maybe slight tenderness, if any. To diagnose asymptomatic apical periodontitis, several factors should be considered. Firstly, the tooth should not have any symptoms during percussion, and there should be no response during pulp tests indicating pulp necrosis. Also, a radiograph usually shows a radiolucency at the tooth's apex. Next, we have acute apical abscess, which is an inflammatory response to infection and necrosis of the tooth pulp. Acute apical abscesses have sudden onset, and the patient may have spontaneous pain, pus formation, and tissue swelling. If a tooth has an acute apical abscess, it will be extremely painful to biting, pressure, percussion, and palpation. In addition, it will not respond to any pulp tests. A radiograph may show a widened periodontal ligament space or an apical radiolucency. The patient may also have a fever, and the lymph nodes in the head and neck region may be tender. A chronic apical abscess is a slow inflammatory reaction to an infection and decay in the tooth pulp that occurs gradually with little to no discomfort. This lack of discomfort is due to pus intermittently discharging through a sinus tract associated with the abscess, either intraorally or extraorally. In general, a tooth with a chronic apical abscess will not have symptoms. It will not respond to pulp tests, and an apical radiolucency will be visible on the radiograph. Although the tooth may not be sensitive to biting pressure, the patient may notice a difference compared to other teeth on percussion. And the primary difference between a chronic apical abscess and asymptomatic apical periodontitis, which are both asymptomatic for the most part, and present with an apical radiolucency is the presence of a draining sinus tract. One specific thing that you could do if there's a sinus tract is try to insert a guttoperitoneum through the opening until you feel resistance and take a periapical radiograph. This way you can precisely identify which tooth the infection is coming from, because the tooth located immediately next to the sinus tract is not always the cause of the infection. Okay, that's all for this video. Hopefully everything was easy to understand, and if you have any questions or suggestions for future video topics, please feel free to leave them in the comments below. And of course, don't forget to subscribe and hit the notification bell, as I plan to upload much more. Thanks again for watching, and I'll see you in the next video.